Can you hear me all right?
Mm-hmm.
Okay, well, thank you for joining us, Dr. Totten and Naima, Dr. Alver, but we could call you Naima. Kat, did you want to do the introduction?
Sure. So the one who was speaking is Maria. She's our associate DEI coordinator. My name is Katarina. I'm the DEI coordinator for AWS, the National Medical Student Committee. Here we have with us is Dr. Totten and Dr. Alver. I can do the brief introduction for Dr. Totten in case anyone didn't get a chance to see our post from yesterday. So Dr. Crystal Totten, an assistant professor in the Division of General Endocrine and Metabolic Surgery at the University of Kentucky. After receiving her medical degree and completing general surgery residency at the University of South Florida, she completed a fellowship in minimally invasive surgery and abdominal wall reconstruction at the University of Kentucky. In addition to a robust clinical practice, she serves as an assistant program director for the general surgery residency, focusing on simulation and holistic interviewing, and as co-vice-chair of Professionalism, Integrity, and Equity within the Department of Surgery, formerly known as the DEI Taskforce. Yeah, thank you for being here, Dr. Totten.
Thank you for having me.
Of course.
And Dr. Alver is an incoming cardiothoracic surgeon in resident into the integrated I6 program in the University of Washington. Is there anything you want to add? I didn't have a lot of information.
No, I mean, that kind of sums it up. I'm very early on to my career. I went to medical school at Oregon Health Science University. So I think that's the only addition to add.
Perfect. Well, thank you both for being here.
Yeah. So this is in continuation of the DNI what is it? About our diverse perspectives in surgery series. Oh my goodness. Maria's already got one of these under the belt, and this is my first time joining live, so excuse me for any brief interruptions. But I guess we can just get right into it. We wanted to just first see, if you guys can share a bit about your personal journey and what motivated you to pursue surgery as your main specialty. You guys can begin.
For me, I always loved, I knew I wanted to go into medicine pretty early. My mom was a manager, and I was always sort of around the hospital hearing different stories of things. My dad worked in sort of a gas lineman situation. We were always building things as a kid. And to me, surgery was the perfect fit. I could use my hands, I could construct things. I could use my ability to really see the abdominal wall and see different things, take it apart in my brain, put it back together. So surgery was always really a natural fit for me. I went into it thinking I was going to do anything but surgery and realized the only thing that I loved, and it was the only thing that was going to make me happy lifelong. Ultimately stuck through it, matched, and then have made a great career out of it since.
So for me, I also kind of decided that I wanted to go into medicine at an earlier age. I had some difficulties growing up, and doctors were these incredible mentors who really helped me get out of a sticky situation. So that was kind of the impetus. And then I always leaned towards surgery. I don't think I have the patience for medicine. And so I really like the security and the finality of doing a procedure and then knowing that you got the tumor or you fixed the knee, or in my case, the heart. And CT surgery specifically, I could go on for a while about it, and I just had lots of practice doing just that during the interview trail. But I think that I really love that you get some of the sickest patients in the hospital, and then in an afternoon you can turn it around and give them decades that they otherwise wouldn't have. And I think that's an incredible gift to be able to give to our patients.
Wonderfully said, both of you. I'm really happy to hear about your journey into medicine and specifically surgery. But I also wanted to know, and hopefully the audience wants to know, what are some of the barriers that you faced in this journey? And if you could talk more about that.
I'll go a second, if you will, because some of my work at this point.
Yeah, so I think that being a gay person, and specifically in the Pacific Northwest, I didn't expect to face a lot of issues navigating medicine. I live in a very liberal area. I went to a very liberal college, a very liberal medical school. But when I was getting ready to apply for residency, for those of you who don't know, the match rate of CT for integrated programs is around 36%. And so most people, 99% of applicants will dual apply to general surgery and CT surgery. And when I was getting ready to apply to CT surgery, in my personal statement, I mentioned being a lesbian and how that really informed a lot of my DEI work, and sent it off to attendings who had been mentoring me and some of my friends who were in these residency programs. And to my surprise, I got a lot of people coming back with feedback that I should remove the fact that I'm a lesbian in my application. And so I reached out to some more people, and you know, mind you, I didn't talk to every resident in every program that I interviewed for or applied to, but there is this general consensus. Most places except for the University of Washington, they were the only place that told me to actually keep it in as a strength. And so I was faced with this dilemma of, do I remove this thing from my application and increase my chances of interviewing and remove the possibility of even a subconscious discrimination, or do I keep it? And I did make the decision to remove it, and it was a really difficult decision to make, though I did keep it in my general surgery application, and it was a much more welcoming environment. And there was a lot of LGBTQ representation in Gen Surge that didn't exist in the CT surgery interviews. And I think for me, it also really impacted the way that I went about doing my rank list. I was very fortunate to match into my #1 program, but with the knowledge that even if one person was anti-LGBTQ or maybe had an unconscious bias, they didn't even have to be outright. If I lived in a state that also tended to have laws that didn't necessarily protect LGBTQ people, it was a really difficult for me to imagine living somewhere for 6 to 8 years where not only is the state a place where I could face issues, but my institution in of itself could also be a place where I face issues. And so I think the obstacles for me and for a lot of people, I'm sure, when they're going into these fields, our geographic locations can be limited. And surgery, especially, you know, when you're going into subspecialties and surgeries, they're so competitive to begin with that you're really disadvantaging yourself by removing a lot of these possibilities where you have to choose between, I want to do this as my career and I want to feel safe and comfortable in my environment.
It's really important. I had to go through that, and that you received that feedback. For CT surgery, just for context, I mean, it's like less than 5% win, and to, you know, having very minimal out queer representation in CT surgery. It is that we need to break into even more, in addition to breaking into as queer physicians. So I'm sorry that you experienced that. I'm glad that you matched at a program that it sounds like you're going to feel at home and be able to be your authentic self. Really, that's super important. For me, you know, I trained, you know, circa 2009. So it's a little bit different in the sense of it was still a pretty significant boys club. I was out. I've been out in my life since I was 18. It was a choice that I made, supported by family, but still went through, you know, the struggles of being out. I had issues and discrimination in medical school, but there was also another lesbian medical student in my class, so we kind of banded together. In residency, I was the only out person in my residency program. Of course, dealt with, you know, some discrimination and things like that, but was able to get excellent training. And then I very much am out as an attending. I've made a point on that at every step in my career for visibility. My wife comes to all of the, you know, residency program stuff. We have other queer faculty here that have come after me being here. We have many residents across all of our disciplines who are varying degrees of comfort as to their outness. But I think being visible makes this an opportunity and an idea for the next person behind you so that they can be comfortable. So
Absolutely. And this kind of ties perfectly into our next question. I know you guys already started talking about representation and making sure that, you know, you're making the environment comfortable for the ones that come after you. Could you share some stories about your own personal experiences with the importance of representation and diversity in the surgical field specifically?
Yeah, absolutely. Are we talking, just so I know question-wise, for patients or for like medical students, residents?
Involved, really. I think that, you know, this type of representation doesn't just extend to the doctors, it also extends to everybody that's in the healthcare field, including the patients.
Absolutely. So I think for me, like I said, I've been out sort of every step of the way, in part for my own comfort and safety. Also, I didn't want to live my life partial. I didn't want to always be worried about who I told what to, what sort of mistruths I needed to keep up with. So the truth to me and my living out was the only way I could be authentic to myself. Same way in the operating room, I talk about my wife, right? I have to talk about my spouse in the same way that my techs and the rest, my colleagues talk about their wives, because that's my life. And I talk about my dogs and everything else at home. And that sort of leads to additional conversations. And I hate to use the word normalize, but it makes it where the conversation is no longer awkward. It's an everyday conversation communication. We are sharing our common ground versus maybe the one thing that differentiates us, and that's who we love. So for me, it really opens the discussion with scrub techs, with people in the room, different generations, because everybody in an operating room can be a varying generation. I am happy and love here working at the University of Kentucky, because even though we are by definition, you know, a Republican state, Lexington is a nice little safe haven. We have a big fairness ordinance, meaning anti-discrimination laws when it comes to hiring, housing, etc. The College of Medicine 2 years ago, when we were doing a lot of our DEI work, created these safe badges. So it's the progressive pride flag with a safe on it. And it's amazing how many of these that you'll see around campus. And it's everyone from people who identify in the community to also being allies. And I'll wear it. And for the beginning, it was like, where did you get that? I want one. And it was really, really amazing to now, I would say, probably 40% of our entire faculty within the hospital will have one on their badge. That is everything from people, you know, cleaning to cooks to, you know, operating room staff. And that visibility is super important for all of us to have a common ground in communication, to know that we're in a safe, respectable place, and for, you know, regular patient safety and culture.
Yeah, definitely. I think since I'm newer in my career, I haven't been in the mentoring position for very long, but very happy to have anyone reach out to me after this for CT questions or LGBTQ questions. I think that I've had a lot of really impactful patient experiences, and one immediately comes to mind. It wasn't in CT surgery. I was in one of the general surgery rotations I did, and we had a consult for this man. He was a younger guy, I think in his mid 40s, with HIV/AIDS and a really low CD4 count. And he was in with a bowel obstruction, and the question was, is it lymphoma or infection? And I have a little rainbow pin on my badge that I've had as soon as I got a badge. I was very excited to put it on there. And he opened up to me about being homosexual and how the reason why his CD4 count was so low is because he was trying to attempt suicide by HIV. And the reason that he contracted HIV wasn't because he was doing drugs or anything of that nature, but because when he was in his early 20s, there was a man who knowingly had AIDS who assaulted him to give him the virus. And he had faced discrimination throughout his life because of this. And the fact that I had a little rainbow pin, and he asked me about my orientation, and I told him, you know, that I was a lesbian. And then he opened up about this story to me. And then I found out, okay, well, this is why you're not taking your meds. It's because you're trying to commit suicide. And so I think that just kind of, as you were saying, having a place where patients know that they're in a safe place where they can say, okay, hey, I need help. We had another patient who was using he, him pronouns to refer to her partner, but I found out later that she actually had a wife and there was possibility of domestic violence. But a lot of the times patients who are unsure if their providers are going to treat them differently for being queer might use opposite sex pronouns. And so the fact that she didn't want to maybe reveal the fact that she had a wife also concealed the fact that she might have been in danger for domestic abuse. And so definitely having representation in your med students and your doctors and your nurses and all different levels that are opening up these avenues of communication so that you don't miss something like suicidal ideation or domestic violence of queer people is really important.
Yeah, definitely. Those are really important experiences to highlight upon in the patients, and the fact that you were able to do that as a medical student was already showing that, you know, this is important now, and especially with the changing political climate and everything that happens depending on whatever region of the country you're in. Do you guys feel like that has impacted your clinical work at all, like with the recent developments in any anti-LGBTQAI legislation? I'm not sure about the state in like Washington, like whether or not it's affected anything significantly, but I know that Kentucky and West Virginia recently, or at least in the last month or so, were very keen on pushing anti-trans healthcare legislation for kids. And I was wondering if that's already affected your practice at all.
It has not affected my practice based on, the patient population that I see because I'm an adult provider. However, I have friends that it's affected, parents of trans kids that I am well acquainted with that it's affected. We have a very large adolescent and trans health, clinic here, and it affects how they have been able to counsel patients and families. I'll just outright say it's completely inappropriate and unfortunate, the legislation, in my personal opinion, and how it's been passed, the misinformation, and really the reasoning behind why it's being done. It by no means helps trans youth, period, plain and simple. It does not help anyone. Our institution has really altered how it counsels some. The idea that actually gender affirming surgery is being provided to minors is a misnomer. It's complete misinformation. But it does affect the health, safety, the mental health of a lot of our patients and our families here in Kentucky and in the surrounding areas, from Tennessee, from West Virginia, from Indiana, Ohio, which have other similar concerns. It also affects the outward stress of my adult trans patients who come in and have this sort of layer of fear already upon them as to how they're going to interact with their providers, either based on historical interactions or now even heightened by the political climate. So it's even another reason as to why, when they realize that you're an ally or part of the community, you just literally see this layer of stress melt away from the social impact of things so that you can then focus on their health and only their health.
Yeah, because I live in Washington and went to medical school in Portland, I haven't experienced or seen firsthand how the legislation has affected LGBTQ populations. It definitely hasn't had as much of an impact in Seattle and Portland, because luckily we have a lot of protection there. But just as a whole, I think it's increased the stress, and mental health is definitely being affected across the country. But luckily people, at least at the institutions that I'm training at, have a lot of protection there.
That's really great to hear that you guys have the degree of protection that you have, and I know that there are definitely certain acting physicians, patients who may not be as fortunate across the country. Maria, do you have any other questions to add on as well?
Yes. So we wanted to know what initiatives or changes should the surgical community implement to um, improve healthcare access and outcomes for LGBTQ plus individuals?
Education. If you don't know something is existing, how are you supposed to help treat it or help move the needle forward? So awareness, panels like this, okay? If you stay in your own bubble and you never know what another perspective is, what another person is experiencing, if you haven't learned the history of what is happening, then you're not going to be able to provide the best care for your patient. As a surgeon, right? If you don't know 5 different ways to treat something and you're a one-trick pony, are you really providing the best patient care? The answer is no. So if you only have one perspective and you don't really understand what it, the context that a person of color may have experienced their life, so you're not going to be able to relate to them and know those ingrained, but you are able to then have the knowledge and at least the conversations and the awareness of multiple perspectives. So I think that we need to treat the social aspect of things the same way we treat the hard skills of becoming a surgeon and a physician. And I think it really starts with education and learning different perspectives, learning about how to interact, learning about, say, pronouns or what different, medical situations will arise with different populations. Same way that you would, treat hypertension different depending on ethnicities, right? It's a real thing. We should think about all of these perspectives when we're treating our patients.
Yeah, I definitely agree. I think, again, for lack of a better term, normalizing it more within, the community. I think a lot of the times you have these initiatives that are pushing towards more inclusive environments, and traditionally you might have pushback from older generations that are like, oh, it doesn't really matter. All that matters is merit. There is actually a huge debacle at the Society of Thoracic Surgery conference not too long ago, where the leaving president had an entire presentation about how affirmative action shouldn't be implemented and how the only thing that matters is merit. And luckily the community really pushed back. But these conversations are had behind closed doors, and residents who are trying to normalize even something as simple as wellness and having regular work hours and having parental leave and time off, these ideas are scoffed at. But we have to continue to push back and to make it part of the normal conversation, so that eventually the majority is going to be the people who are normalizing being out and having your pronouns respected and not having fear of using the pronouns of your partner, fear of any kind of discrimination or retaliation. So yeah, definitely just things like this, panels, education. And I think it also means a lot to me when the institution itself really celebrates things like Pride, where you have flags up and messages of support and encouragement. And I think that really shows not just the providers and the hospital staff that they're being supported, but also the patients themselves.
Yeah, absolutely.
One thing I want to add, I'm sorry, go ahead.
Absolutely, Dr. Totten, go ahead. This is your guys' time to talk.
Oh no, you're good. One other thing that I really wanted to add is being an upstander. Okay, so the word bystander, upstander is kind of intermingled, but the idea of when you see something, say something. So if somebody uses a derogatory term or they laugh at another individual, or there's a really uncomfortable situation, there's different ways to interact or respond to situations, and there's all kinds of variables depending on your personality. One is to check on the person afterwards, right? That's a great one-on-one thing to be empathetic to that individual, but it does nothing for the culture of the situation. So finding the best way for you personally to object in that actual episode of when it's happening, when any discrimination is happening whatsoever, is the best way to really cut it down and to change culture. And you don't have to be aggressive about it. Sometimes, honestly, even if you just say, I'm sorry, I didn't hear you, can you repeat that again? The person saying the comment is going to be like, oh, that was not a great move of mine, right? Or you can be like, oh, can you explain that to me? I really don't understand your train of thought. to have to then rationalize and put words behind it, the individual making the offensive comment oftentimes will realize, it wasn't quite appropriate for the conversation and will kind of cower back. That is the best way for you to push the needle forward when it comes to building an inclusive culture, is that allies are able to really step in and help support everyone.
Yeah, absolutely. It's completely true. I guess in speaking towards these, ideas that there should be changes with regards to LGBTQIA healthcare. Have you guys had the chance to work on a more like institution level to help implement some of these changes that you have been mentioning, or if there are any changes that you have been able to work towards in either, I guess for Dr. Alver, your medical student career, and for Dr. Totten in your career thus far?
I'll let you go first.
So again, because I went to OHSU, which is a pretty progressive and like liberal institution. Sorry, my cat walking across the screen. We had some student groups, but with COVID and with the Black Lives Matter protests, I think that took a lot of the kind of was like at the forefront of a lot of our initiatives and a lot of our focus. And so I've been involved in initiatives like that, where we created scholarships and created videos, video protests to stand by the movement. But I think that working on specifically LGBTQ initiatives within the institution wasn't something that I was involved with, just because it didn't seem like there was necessarily a need for it at my institution. But then again, I'm very straight presenting, I'm cis, and so there's a lot of obstacles that I myself am not aware of that a lot of my colleagues and fellow students definitely had to endure. And I think that those are they generally have people that you can report to and anonymous advocates. But I guess to long answer your question, long answer to a short question, no, I haven't necessarily yet been involved, but I am really excited and passionate to start getting more involved, especially now that I know that there is still a lot of discrimination against LGBTQ people. I was actually really surprised with my experience applying to CT surgery and navigating that. And so it's definitely something that I have made for a goal for myself moving forward.
I have a question. This is me curiosity. Did you experience discrimination on the interview trail, or was it the theory of not wanting to make yourself have discrimination?
It was the theory. So I wasn't out during my interview trail. There was some, potential sexism that was involved, and definitely a lot of sexism while I was getting ready to apply and while I was doing some away rotations, all of that. There had been some comments. So they have this like Excel Google sheet that all applicants use, and there was a misconnection sheet, and somebody started mentioning me in like a slightly inappropriate way, and then somebody else anonymously outed me as being gay, and then that kind of started some inappropriate comments after that. And so it was more specifically with the co-applicants than it was with the faculty or the leadership on the trail, because they didn't know.
I find that a lot. So I do a lot with like medical students and like interviews and that sort of thing. And there's theories about how out you should be and how much you should sort of be your authentic self and what opportunities it may take away from you. But I think the flip side is, if you identify and you want to be out in your life, you likely want to know those things before you show up July 1. Mm-hmm. So a lot of advice I give, queer applicants is figure out what balance you want to lead, and then that pushes your decision forward when you get there. So I was supposed to answer a question. I forgot what it was. What initiative?
Yes. Any institution-wide work that you've been able to do?
A lot. Let me sort of bring it. So we have a College of Medicine LGBTQIA task force panel that covers everything from changing or adjusting medical curriculum to be inclusive. So changing, phrases and ensuring that, the HIV patient is not always a gay male, right? So like the low hanging fruit in the sense of changing a lot of the stereotypical things that have been used to push an idea forward that isn't generalizable to one specific group. It actually can be, used of many, many, many patient identities. So clearing that out of the curriculum. Increasing visibility. We have a mentorship program. So I have anywhere between 1 to 3 mentees, here within the College of Medicine, who are looking for a mentor and identify as part of the community. I also sit on the College of Medicine. I'm an ambassador for the actual head of college, like the big College of Medicine that has groups from every single department, and how we push forward diversity and inclusion. And then I lead the professionalism, integrity, and equity group here within our department. So we do education within the department on all kinds of different topics. And we've really gone to the professionalism, integrity, and equity because surgical excellence requires perspectives from multiple different backgrounds. And you can bring a bunch of individuals to the table, but if you don't actually listen to the perspectives and you don't actually include them in the conversation, you're not really pushing the needle forward. So professionalism and integrity brings forward this idea of an inclusive culture and bringing everyone together, and it actually being the ability to push the institution forward. There are lots of struggles within that goal, but it at least is the idea that we are trying to push things forward and continue to improve upon our progress. And then has anybody heard of the Association of Outsourcing Allies?
Yes.
Yes.
We have like over 300 members. There's like 21 institutions that are on board. It's a young society, but it's awesome. And you can really connect with people who are at multiple institutions for mentorship, for really to help throughout your entire career progress forward. Some of my, people that I've met in that organization, I then work with in a bunch of other organizations as well, because our careers all overlap.
And thank you for sharing that. And something that you touched upon was like the stigma basically of HIV and AIDS and associating certain diseases with certain groups of people. I've heard before from others who are married to a man is married to another man, and they have noticed that when they go to the doctor and they're asked about their sexual activities, that they're classified as like man who has sex with men, and then that increases their bill, as well as like increases like the amount of testing that they need to get done, even though they're monogamous. And it's just so then they've said that whenever they have another they switch providers, and then just they don't feel safe mentioning that they are married to someone of the same sex, because then they're just stigmatized. What do you think about that? Has any other examples of like stigmatization in that regard?
I want to break down something real quick, because I think there's a little bit of misinformation or misunderstanding in that.
Yeah.
A bill cannot be adjusted based on individual like things. Like your bill's not going to be higher based on X. That's just not a bill. We bill, unfortunately, based on time and or complexity of disease process. So the only way that one's bill could be higher is if you're doing additional screening or testing, and that's based on those testing prices, not based on the actual physician to physician discussion bill. So that part, is a little more nuanced than that. When it comes to do people have extra testing that they don't really need? Yeah, of course. Anytime I go for a procedure, they want me to give a pregnancy test. I say, paperwork, please. That's why I'm like, I have a wife. I'm in a monogamous relationship, and it would take some serious intent for me to. So it's just a matter of I'm a woman of childbearing age. So therefore I have to take a pregnancy test before, or I have to sign my own risk associated with it. So there are a lot of things that we do throughout medicine that are protocolized to not miss certain things, but they are historically set into bias. And I think trying to figure out how to teach people to treat the patient as an individual versus a protocol is the best way that we can avoid some of those stigmas and generalization.
Yeah, definitely. To piggyback on that too, as a lesbian and somebody who, you know, is only active with women, I think a lot of the times when I was younger, I was told that I didn't need as regular pap smears, or that my risk of HPV was going to be much lower, and that's, you know, not a isolated experience just to me. A lot of women who have sex with women are seen as lower risk individuals, but you know, they're still the same, you know, maybe not the same risk, but women who have sex with women are very much capable of contracting HPV. And so if you're not screening those individuals, then it's possibly, like, they're possibly going to be missed, and it can lead to cervical cancer, or they have to get more invasive procedures. And so also skipping screenings, in addition to adding additional screenings that aren't necessary, is also an issue.
Right. And on that note, what unique challenges or considerations have you encountered when working with LGBTQ plus patients? I know you both already talked a little bit about that, but if there's anything else that you would like to talk about in that regard.
I think before marriage equality, it was even more difficult. I think now, since thankfully we have marriage equality, progressing through, you know, hospital legislation and different things to make sure that the significant others of our patients have their, you know, appropriate rights respected has been much easier. I will tell you, one of the challenges that I find is, depending on the individual, and I don't want to generalize, but some older same-sex couples tend to have a much smaller village around them as far as family and social support. There may or may not be kids in the mix, or, you know, nieces and nephews, or things that as they become older individuals and need more support after an operation, we have to have a lot more conversations beforehand as to sort of who's going to be your village and who's going to help you after this surgery. I ask every single patient of mine, it's just sort of part of my spiel of, like, you know, who's going to be with you to help take care of you after surgery. We always talk about that. And then sort of what things are going to impact your post-operative recovery. Who do you have to lift? Who do you have to take care of? Do you have large animals? I live in Kentucky, so I have farmers and all kinds of stuff like that. So that helps me understand that social dynamic of it afterwards. But I will tell you, sort of, I think that is a little bit more of a unique challenge of figuring out and making sure your patient is going to have all of the support they need after you've cut them, and after they've healed, and after they've left the hospital, more than anything else.
I haven't had any specific experiences, but some come to mind that would be possible, and I'd really love to hear your opinion if you have any experience with that. But oftentimes trans individuals who are on hormone replacement therapies might affect certain treatments, especially if you're talking about breast cancer. And so when you have to stop those replacement therapies, that also involves a lot of, like, mental and emotional trauma for the patient as well, because it's affecting, you know, their transition or their treatment plans. Maybe you've had personal experience, or you've heard of actual instances where this has been the case, but it is something that I thought of when you asked that question.
You're saying in the sense of someone who is on testosterone therapy but then has a positive, like, I mean, breast cancer screening, and or is a male transition to female who had male onset breast cancer underneath implant?
Yeah, so any kind of
Yeah,
I guess treatment, yeah, that would be affected by hormone replacement therapies.
I think those I've never experienced that situation. I think they're incredibly rare, and I definitely have to be taken care of with significant care, and including the mental aspect that it would involve, and sort of variation transitions. The same thing, would go through individuals who are on hormone replacement therapy for postmenopause or other things like that. So I definitely think that there are unique caveats based on the mental health component of it. And I think picking your provider would be very important. But I don't know the frequency at which that occurs, and then to how much it would then affect their overall transition process.
I see. And definitely, I think that mental component ties back into what you were talking about with the social support that's needed for individuals. I know, like in school, we do learn about the support needed for more financial circumstances if families are facing certain financial burdens. But I think the emotional aspect, and this also ties into, I guess, the general societal negative stigma around mental health, that ends up becoming more pervasive, and it ends up compounding on individuals, especially from vulnerable populations. I think one thing that I also wanted to ask, given that we are part of the National Medical Student Committee, we're not practicing physicians yet. Do you both have any advice for any individuals like us, or any, I currently I'm identifying as straight, but any individuals who are part of the LGBTQAI plus community who are interested in pursuing medicine, or interested in pursuing surgical subspecialties in particular? Do you have any advice about, their career into medicine and how they can seek that support?
Yes. Well, so yeah, as somebody who just went through the process of applying to residency, kind of already speaking on my experience of how I was able to keep my sexual orientation in my general surgery, but not my CT surgery application. I think that it is, this is it's kind of a hard question, because again, like, I face the possibility of maybe not being able to get into a CT program if I was out in my authentic self, and I've been out for over a decade now, and so it's not something that is newer to me. I'm very confident and comfortable in my identity. I think definitely reaching out to the Association of Out Surgeons would be a great starting place. I can have my email provided to anybody who has any questions or wants to know a little bit more about the way that I navigated that. I think also what I realized when I was in medical school, if there isn't something that already exists, don't be afraid to create it yourself. And I think that is why I found a lot of success in my application specifically, is because there were a lot of things that I created because I saw a need for something, and I was like, well, I'm going to do it since nobody else has. And so, that might take a little bit more effort on your part, and reaching out to people from other institutions, especially if it's for LGBTQ type clubs or events within your own institution. But there are so many resources out there, and so many people who are excited and willing to help mentor you at every single stage in the career. So just ask, and, create something out of nothing if you need to, but we'll definitely be here to support you do that in doing that too.
I think my personal opinion is nothing should influence you out of medicine or out of a certain subspecialty if it's what you want to do. You can make a way, you can figure it out. There may be hardships that you have to go through, unfortunately, given just society as it is, but there is nothing that you can't do because you were from this community or this ethnicity or this, sexuality. So there are no, just straight up barriers if you shouldn't do X, Y, or Z. I think seeking out mentorship is very important, because there are so many, theories and misnomers and like different things out there. And they're like, if you want to be a woman, don't go into surgery. All right. We're all here, thankfully, because we're wanting to dispel that myth. You can have a life, you can have a family, you can have whatever sort of situation you want, and create it. And I think for anybody going into medicine, and I mentor like high school students and undergrad, and then also medical students, because that entire pathway process is super important. But anyone wanting to go into medicine, you have a will, you'll find a way. So just stay true to who you are, and I think really know yourself, and then figure out where you want to be.
Yeah. Thank you for those words of advice for anybody who's listening, including for us as well.
It will get better.
We sure hope so. For everyone's sake. Maria, do you have any other questions to add on?
I think we were just, our last question was any resources for people wanting to go into surgery, but I think you guys pretty much answered that in your last answers. So we could let the audience ask any questions if they have any.
I know there were some questions from before. I was going through the comments as they were going in, but I don't know if this was particularly for this panel, but somebody was asking about pursuing CT, and I think about general advice that you would have for any medical students that are interested in becoming cardiac surgeons.
Yes. I feel like that's a panel in and of itself. I think kind of it applies, my last answer kind of applies in general. Don't be afraid to think big. And so go outside of just your institution. Don't think of only leadership within student groups, but think of national organizations. Don't be afraid to, reach out to people across the country. A lot of my mentors didn't go to my institution, and they opened tons of doors for me because I reached out and just asked. I think also you don't necessarily have, obviously you need research, and so kind of starting that early on, and then just making sure that you kind of have maybe multiple projects going at once just in case some don't come through. Unfortunately, you have to be really good at time management. And I think the last thing too is just whatever you're passionate about, definitely do the things you're passionate about in CT surgery. But if your passion projects lay outside of that, like my passion projects were really involved in like mentoring foster care kids and immigrant youth. And so I did a lot of work in that. People want to see that you're willing to make change, that you're willing to make moves, that you're going to execute something, because that's just going to make an incredible provider. So definitely just pursue your passions, think big, and if you don't get into a CT integrated program, you can always do general surgery and then do a fellowship afterwards. And so it's not the end of the world if you're not in one of those 49 programs that are in the country.
Who's counting?
That's such a low number of programs around the country. Wow. Mm-hmm. I'm not even sure if that person's still on for listening. I will be putting the live on the page, so if anybody wants to go back for reference, they'll be able to go back to the live and see any of the topics that we were discussing so far. Anybody else have any questions that are tuned into the live? No.
Something that you guys have gotten out of this panel. So what's something to play?
I'm sorry.
For us?
We're gonna flip the script a little bit because there's no question. So
there's also a question, but we can answer it. We'll leave that our own reflections for last. But hi docs, may I reach out to you guys later through email? I am a gay Latina applying to surgery this year. Okay, yeah, they can we can include your emails in
or would you guys prefer to put your emails in the comments on your own?
Yeah, I can just put my email here. Let's do this one. I have a few, but I'll do.
Yeah, and while you guys are doing that, I could reflect on my experience hearing. I love doing these panels because you get to learn from and I'm really excited that we got to see those two perspectives of an attending and an incoming resident, and just how inspiring you both are with everything that you've been through and how you've advocated for your patients, and how just being an advocate and having that representation has helped, from what I hear, so many, and I know there's many more that you might not even know about, but mostly from what I feel that I could do is just be an advocate and destigmatize just what the medical system has set out for LGBTQ individuals, and just be an ally and from what the advice that you have given us, and also reach out to the the Out Association?
Association of Out Surgeons.
Of Out Surgeons. I have them on Twitter. I have to follow.
We tagged them in the original promo post for this. I don't know if anybody from there has made any note of this going on. But before I answer, there's actually another question that was asked in the chat. Someone asked, are there opportunities to connect with you guys through schools, clubs, organizations? I'm a pre-med student, and I'd love to hear more from you guys while also offering such an opportunity to my peers.
Yeah, so you can just contact me through the email that I put in the comments. I think that those should be available still if you scroll. I've never done a live thing before, so.
Me neither. So, I mean, I'm hoping that the emails are still there.
They will be. You
okay,
just have
good.
time, they'll still be there.
Actually, I could pin it. So, well, let's see.
Oh, that's great. Okay. She knows better about this than I do. I guess back to Dr. Totten's question for Maria and myself. In terms of what I learned from this panel, I think that, you know, I'm not particularly exposed to the community as much during my practice, or I'm not even in practice yet, during my clinical rotations, let's say. A lot of the diverse backgrounds are more focused on ethnicity and race, since I'm in New York and I work with a lot of minority races as opposed to, you know, members of the LGBTQAI community. So I know there's definitely a lot that I have to learn in terms of interacting with them and in terms of, you know, providing the best possible treatment when I go forward in my career. A lot of the individual mental struggles and lack of social support that can happen in the community is not something that I really thought about before coming to this panel, even though I know about, you know, there being such legislation being put in place. You know, I think the impact of it on an individual level is something that, you know, I have yet to fully understand the impact of as I go forward in my career.
And I promise you, you've taken care of patients that are part of the queer community. They just haven't been out. And that's a matter of sort of their comfort and different things. And the more you ask sort of who's going to be around to help take care of you, the more you ask the questions, the more actually your patients will be forthright with you, especially if you have some sort of thing on your body stating that you're an ally. Yeah. I found tremendous change in the interactions of my Black patients when I had a BLM pin on, and when I would move my hair and they would see my BLM pin. The amount of just relaxation and comfort that brought, we had a much different relationship. I wish that wasn't so. I wish that, you know, block wasn't there. But as a white, cis, you know, gender straight passing woman, right, I have to wear my outness and wear my support a little bit more than other individuals because I don't have that visual intersectionality. So I think that makes a big difference. I wanted to jump back real quick for like opportunities, because I missed the thing that's like for high school students and for like pre-med and different things. If you look around your institutions, a ton of places, College of Medicines have pathway programs now when it comes to high school and to undergraduate students to help get you involved. If you're a third year, or now I guess for next year, you're a third year medical now looking for general surgery, or actually any rotations, so we do it for plastics, CT, and whatever. UK has a stipend for you to come for your fourth year AI. So we help pay the moving cost and everything else for you to come for a month and stay with us. If you look at the AAMC, there's a bunch of different, they're mostly titled diversity scholars. Ours is for anyone from, we have kind of like just, it's backgrounds. Like, so it's like there's a financially disadvantaged background. There's, you know, a change in like sexual orientation, any sort of minoritized background is how we phrase it. You can apply for that in order to have a stipend to come do your AI here at the University of Kentucky and see what we're all about. So a lot of your College of Medicines will have pathway programs for undergraduates, for the College of Medicine, high school students for undergrad, and then also medical students for residency programs.
That's an awesome opportunity. I'm still I'm just about to start rotations, but when I do my OAs, I'm definitely gonna look into those. Oh, here's Kat. She left for a second. But
Yeah, I will say that away rotations have become even more important in the era of virtual interviews. I'm actually working on a couple of projects right now talking about away rotations, and unfortunately, away rotations definitely disadvantage anyone who's financially insecure. And so, take advantage of resources like Dr. Totten mentioned, and look for institutions that'll pay. I was able to do one of my away rotations because I had a scholarship to do so, and so it, especially within CT, if that's what people are interested in, it's almost kind of a requirement at this point now that you're not there in person to interview.
The interview process will change, by the way, this upcoming year. You'll have virtual interviews, and then they will close. We, as like residency programs, at least for general surgery, will, and then there will be a period. Sorry, my battery stopped. We'll put our rank. And
I didn't hear the last thing that you said. I am also sorry. I don't know how to use a live, and I accidentally left for like 2 seconds before I came back on.
my battery, but I have 20%. We're fine. So residency, so virtual interviews, typically they'll be done by January. Residency programs will put in their rank list, and it will close and be sealed. And then the ability to do second looks will happen. And then the applicants will put in their rank list afterwards. So at least for general surgery, that is how the world is going to work. So there will be opportunities to go back. And again, that also depends on your capability to travel around the country to your top whatever 5 schools and be like, hey, this looks like in person what it looked like in virtual. Every hospital, every OR looks the same, to be frank. More about, can you get the vibe that you need to make a decision from a virtual environment? So
last messages to our audience. I know we're reaching the time.
thank you to anyone who signed on. I think that this is a really, you signing on meant that you're open to listen and have a conversation, and I think that's the first step. And really thankful that you guys asked me to be here.
Yeah, thank you so much for also inviting me to speak on the panel. And for all of you pre-meds and current med students, it does get better. It's very stressful. And I'm sure Dr. Totten can tell me it'll get better as I enter my intern year. But I'm very happy to be here today. And also to repeat what you said, thank you for all the allies out there who are open to listening to these conversations.
thank you both for being here. We're taking up all your time. So yes, this was an enlightful conversation. It's going to be pinned to our Instagram profile, and all your information will be there. So thank you again so much for having this conversation with us and for sharing your stories with our viewers. Yeah, that's all. Kat, do you have anything else?
No, I think everybody said everything. Thank you guys so much for joining us, and thank you to the audience for tuning into this live. I know Instagram lives sometimes can, just be something that you swipe through the feed, but for anybody who stayed on, it's really great that that you were able to listen to this conversation. And thank you to Dr. Totten and Dr. Albert for joining us. Happy Pride Month.
Happy Pride.
Okay. Bye. Thank you.
Bye.
Okay, how do we